Everyone, thank you so much for joining us. This is our webinar from Dementia Care Aware for March. We are doing it this month with the Alzheimer's Los Angeles organization, and we're so glad to have some of their leading lights with us to talk about D-SNPs today. We're waiting for a few more people to filter in, so we'll get really launched here in just a second, but just want to say thank you to those who have joined. I know it's our precious lunch hour, so really, really appreciate you being here. So one thing just as background, we've gotten a lot of emails, a lot of requests to talk about D-SNPs and the coming changes for us in healthcare because of D-SNPs and sort of what are we required to do, particularly around dementia. So very, very pleased. We'll kick it off formally now to have our presentation today about practical tools and strategies for quality dementia care, a focus on D-SNP members. Again, I just foreshadowed this, but we have two really amazing speakers who know so much about this. Barbra McLendon, who's the Associate Vice President of Public Policy at Alzheimer's Los Angeles, and Jennifer Schlesinger, who's the Vice President of Healthcare Services and Professional Training at Alzheimer's Los Angeles. You may know me a little bit already. I'm Anna Chodos. I'm the Executive Director of Dementia Care Aware, often a host of these webinars. And again, we're just really glad to have your time today. We will have time for questions at the end, and we'll get going so that we can go over some logistics. One thing that you may know about us is we do offer CME. So this is just a quick slide about our CME provider. We'll be giving the information for how to get your continuing education credits at the end. Here's a brief statement of financial disclosures for the speakers today. I'm not really doing much content, but I have a brief one here. So thanks for taking a look. Wanted to acknowledge some of the funding that has been supporting our speakers today from Alzheimer's Los Angeles. And as we've done with past webinars, we're going to be using the chat and the Q&A function for fielding your questions. As things come up and questions are coming to mind, please do feel free to put them in either the chat or the Q&A, and I'll be monitoring that, but probably won't interrupt the speakers until the very end. We'll have some discussion and be able to get to some of those questions. If it's a clarification question, I'll do my best to get that question in as we're going through. But just a note for our speakers, I will not interrupt you as you're going through the presentation. And again, for those of you who just joined, you'll see the CE and CME information at the end. So here we are. You'll recognize us more in a moment as we become the floating heads. I already sort of listed our names and titles, but just wanted to express my gratitude again to our speakers for making the time and sharing their expertise. And so now the learning objectives that we have for the talk are primarily around the D-SNP requirements, how to maximize the role of dementia care specialists in that work, how to identify effective strategies to support and engage caregivers, and how to explain the key components for implementing California Integrated Care Management, which you're going to hear several more times over the course of the talk, implementing that sort of dementia care. We do always kick it off also because we often have a few people filtering in with a quick review of our Dementia Care Aware program, so you know what that can offer and know kind of why we talk about the topics that we talk about. So we offer training and support for clinical implementation. So for education and training, we have sort of a core training around the cognitive health assessment, which you may have read about in the D-SNP policy requirements. But it's really the core training about how to do a practical screen in primary care and goes through some case-based learning. We also have several more training modules on aspects about screening and dementia care. So how to adapt screening to different populations and patients, how to do a team-based model, how to start a brain health plan with patients. And again, we're really committed to bringing you information via webinars and podcasts as information is ever changing and evolving as we see with the D-SNP models. We have a warm line you can submit via email or call the phone number to get consultation about dementia care or dementia care implementation in your practice. And then we work with several teams across the state to do implementation, and we have an implementation guide online as well for doing a screening approach in primary care and associated care pathway considerations for dementia overall. So how do I screen? How do I do dementia care in primary care? If this is becoming more relevant in your practice, please do check out our resources. So the cognitive health assessment is sort of the core of everything. And just to go over it really briefly, what most of our trainings will refer to or train you on, you or your team, is that this is an annual screen. That's really what we're going for the future, is that all older adults and people at risk are getting an annual screen for dementia. It's just a very quick check meant to be doable in a very busy primary care on cognitive and functional abilities and symptoms. So validated assessments for both those things, as well as a quick check on, does that person have a caregiver or support system? It's meant to really set us up as the start of a diagnostic assessment, if that is something we're going to need to do after the screen. And also it's a jumpstart on brain health that can help reduce risk of developing dementia if someone is negative in their screen, or improve their risk of progressing if they have a positive screen and ultimately get a diagnosis of mild cognitive impairment or dementia. And none of it is undoable by other team members. So a dementia care specialist, for example, a nurse, a social worker, anyone could do these tools. They are not meant to be done by a particular specialist by any means. Okay, so you will see in our materials kind of how the screen is broken up and learn how to do it if you do our trainings. And we provide different options for tools that you can use for either cognitive or functional assessments with either the person, your patient, or the caregiver or informant. Okay, so I'm going to hand it over to Alzheimer's Los Angeles, and thank you so much. And again, throughout, I'll be monitoring the chat for questions and really looking forward to hearing them at the end of the session.
Thank you, Anna. I'm going to start us off. So this may not be news to any of you who are with us today if you are involved with providing care for people who are living with dementia. But indeed, the prevalence of Alzheimer's and the number of people who are living with dementia is increasing quite dramatically here in California. You know, a lot of this is because California's population is aging. So the number one risk factor for developing a dementia is indeed age. So as our older adult population grows, so do the number of people who are living with some form of cognitive impairment or dementia. So we're really pleased that you all are here with us today because it is so important that we all collectively work to build a dementia-capable healthcare system from top to bottom, left to right. So whatever door these individuals and families are walking through, they're getting the kind of care that they need in order to have the highest quality of life that they can. Next slide. Now, specifically, we're talking today about people who are dually eligible for Medicare and for Medi-Cal. So let's just take a moment to look deeper into that population. What does the prevalence of Alzheimer's and dementia look like within this population as it compares to the older adult 65 plus population broadly? And as you can see on this slide, there is a significant increase in prevalence within the dually eligible population. Recent estimates of about 20% as compared to a little bit over 10% in the general population 65 plus. So why might this be the case? Well, one of the key reasons is because the dually eligible population is much more likely to have multiple comorbidities. So if this is an individual who has high cholesterol, high blood pressure, other chronic health conditions, many of those are risk factors for also developing a dementia. And so they are more likely to have that cognitive impairment because they are coming with other chronic health conditions. So if you are serving the dual eligible population, it is absolutely, I think, essential for quality care to really take a look at the structures in place to ensure that you are identifying the presence of that cognitive impairment in order to facilitate all the rest of the care that you're providing. So we can go to the next slide. Because unfortunately, only 1 in 5 older adults report getting any kind of a cognitive screen within the last year. And maybe even more alarming is between half and 3/4 of people who were surveyed were unaware of their diagnosis. Now, I want to be careful here and say it does not mean that they didn't get a diagnosis, that they weren't told of a diagnosis. It may mean that they are not recalling that information, but it may also mean that they did not get a diagnosis or that that diagnosis wasn't ultimately documented in their medical record and so has not been communicated to them. And so this lack of screening combined with that many people are unaware that they are living with some form of dementia really complicates care, especially in our fragmented system where oftentimes we are relying on individuals to be communicating as they're moving into different healthcare settings about what their health status is and what their needs might be. And if they're not able to communicate the presence, they or their caregiver, a presence of a cognitive impairment, and as I've said before, that is really going to complicate care if you're giving instructions about activities that they need to do in order to address the urgent issue that may have brought them in, and there's a cognitive impairment in place. Their ability to carry out those instructions obviously is going to be really challenged. So we need to do better when it comes to dementia screening, and hopefully what Jennifer and I are going to talk about here today is going to help move us forward in that direction. Next slide. All right, so we're going to dig in now into what are the requirements for D-SNPs here in California, all designed again to improve dementia care. Next slide. So here are the 4 topics that Jennifer and I are going to be speaking about. We're going to dive into the quality measure that the state is requiring for D-SNPs, talk a bit about dementia care specialist training requirements, caregiver engagement, the real importance of ensuring really integrated caregiver engagement, and then California's integrated care management program. Next slide. Okay, so this is the most technical, perhaps, of the topics we're going to be covering today. If you are a technology nerd, you can really dig into a lot of technical specifications for the quality measure. It is based on the American Academy of Neurology's quality measure. The state of California adopted it a couple of years ago, and it is, I think, fairly straightforward. Indeed, it is the percentage of patients age 65 and older who have had cognition assessed in the last calendar year. And then there's some information about who's in the numerator and who's in the denominator. Now, we're going to talk on the next slide. There are populations that are essentially removed from the denominator. We'll look a little bit about who would not be included in it. But the idea is once the populations that are excluded from it are excluded, what we're really looking for here in an ideal world is that 100% of these individuals would be getting that kind of an annual screen. And you'll see in a couple of slides where we are not quite there yet. But if we can go to the next slide. Okay, so here are some of the required exclusions. They make sense. People who have already had a diagnosis of mild cognitive impairment. So we don't want to be duplicative in what we're measuring. And then there are other exclusions. So if someone is unable to participate for some reason, if they decline it, you cannot force people to be screened. So if they say they don't want to be screened, then they're not, and they are not included in the denominator for the population overall that should be receiving this kind of screening. The full list of allowable exclusions is in the technical specifications, and we have a link in another slide that gives some additional information provided by the Department of Healthcare Services. That hopefully will be helpful if you're trying to understand what this dementia screening quality measure is and how to go about complying with it. Okay, so here's the slide that demonstrates that we do have work in front of us. So for 2024, the average of people so what is the numerator? Who's being screened? Somewhere between 11.6% and 12%, depending if it's an aligned plan or a non-aligned plan. And that is a significant improvement over the previous year where the numbers were in single digits. So we are moving in the right direction. But again, the goal we're trying to get to is that number is 100%, which maybe isn't achievable, perfection, but certainly we very much hope we get a whole lot closer to it than where we stand today. Hopefully, today's conversation will help those of you who are listening in be able to be champions within the systems that within which you work so that you can move this needle forward. So there has been some confusion around this quality measure. In part, I think that's because there are specifications from the American Academy of Neurology, and those specifications don't necessarily give you all of the information you need to understand how would you really go about operationalizing this. Fortunately, the Department of Healthcare Services does have a Q&A document, which again, when you receive these slide sets, a live link you'll be able to use. And so that document provides much more clarification, for example, about what screening tools can be used. So if you look at the American Academy of Neurology, they do not specifically list the AD8, which is a tool that Alzheimer's Los Angeles has trained on, in part because it can be delivered telephonically, which in a state as large as California, it is really an important qualification or important component of any screening tool to make it easier to use. And DHCS clarifies who can do this screening. So just as Anna said at the top of our webinar, it can be done in a variety of settings and by a variety of staff members. So it does not have to be the physician. We have heard some confusion from individuals, again, when they're looking at that American Academy of Neurology specification, thinking that it can only be done by physicians. It can be done by anybody within that setting who has been properly trained to use the screening tool that you're using.
And to shed a little bit of light on that dementia quality measure, the state of California started implementing certain requirements to improve dementia quality care before the quality measure came to fruition. And so it was really important that some of the work that we had done prior in really ensuring that our care managers in the state were trained on dementia with that AD8, a telephonic screen, and then we had that incorporated into Dementia Care Aware. We wanted to make sure that it was also part of the quality measure as well. So we have been able to build on some of our earlier successes and best practices and bring them forward into our current state where we have the quality measure as well. Many of you are probably familiar that there are requirements for dementia care specialists in our D-SNP health plans. There's a training requirement that dementia care specialists have specialized training on dementia care and that they are incorporated into care teams. We must have trained dementia care specialists on our interdisciplinary care teams. And these dementia care specialists must be included in the development of individual care plans to the extent that's possible. So we're very pleased that we have dementia care specialists throughout the state. These are folks, again, in the D-SNP context who are with our health plans, and they are able to provide specialized dementia care to members. So some best practices for dementia care specialists, some of the things that I'd like everyone to think about is what is the workflow that you use for a dementia care specialist? If you have staff that are trained as dementia care specialists, do they have an assigned caseload of members who have dementia? And if so, are there additional criteria for who gets assigned to a dementia care specialist? Is it simply someone who has dementia, or is it someone who has dementia and two or more chronic health conditions? Or perhaps that is someone who has been hospitalized or has had readmissions. It may be someone who has dementia but doesn't have a caregiver involved, right? Which would necessitate a higher level of care and care management services. Or are dementia care specialists used more as like internal consultants? Are they instead of being assigned a caseload specifically, maybe they are consulting with their colleagues or they're coming into ICTs to provide some consultation on cases as well. But I really encourage everyone to think about, if we're investing in the training of dementia care specialists and they have a role on our ICTs and in our ICPs, how are we actually utilizing these folks and what is the workflow for potentially assigning members to them? The more members we identify with dementia, the more we are going to need dementia care specialists. And then we also have to think about what our staff capacity is, right? If we are assigning members to dementia care specialists. Of course, there's staff turnover. So training 1 or 2 or 4 dementia care specialists in a health plan may not be sufficient with staff turnover. And yet at the same time, it may not be feasible to train all of our care managers to become dementia care specialists either. But we really want to take a look at our data. As Barbara talked about, we know what the prevalence is in this population. And even though the data may not show that, if we're running ICD-10 codes or we're looking at pharma data, because we know it is under-recognized and under-documented, but certainly looking at that data would probably give us critical information about what kind of staffing capacity we need for dementia care specialists, especially when there is staff turnover. We do encourage ongoing training. Becoming a dementia care specialist is not a one and done. It's not taking one training and then being done, but it's really being able to look at what additional training opportunities there are, continuing education, to make sure that these folks are at the forefront of providing the highest quality dementia care. And our dementia care specialists too, in practice, should be a bridge to Alzheimer's community-based services and supports. We need to make sure that our healthcare systems are connected to the resources we have in the community that provide families with care and support, and to the broad range of services that we know constitute dementia care best practices. So really thinking about, if you have the workforce trained as dementia care specialists, how do they bridge? How are they a conduit to members to make sure that our families are getting connected with the array of programs and services that your Alzheimer's community-based organizations can provide? So about a decade ago now, in CalMedi Connect, the state's dual demonstration program, Alzheimer's LA, along with several other Alzheimer's organizations in the state of California, developed a dementia care specialist training program. This training continues to be offered on an annual basis, and it fulfills the requirements for the Department of Healthcare Services D-SNP policy guide, and it's actually also now aligned to the CMS guide program and the training requirements and guide as well. It's offered as 4 interactive live Zoom-based trainings followed by 4 follow-up huddles, and it's designed to strengthen skills and knowledge around dementia and the ability to more effectively do care coordination and care management for members living with Alzheimer's disease and related dementias, and supporting their caregivers. I did put the email address if you're interested in that training. When we offer it, we will be happy to share that information with you. But it's really important to take advantage of the opportunities to train your dementia care specialists so that they're most up to date in the most relevant information. Our dementia care specialist training, we focus on the fundamentals of dementia and cognitive screens. We look at disease progression. We train on various cognitive screening tools using a lot of the information from Dementia Care Aware. Focus on dementia-informed lens on safety, whether it's medication safety, wandering, driving in dementia, mandated reporting as well. We look at culture in a state as diverse as California. It's really important that we have a cultural competency lens. So we focus on culture, the full array of the meaning of what it means to be a caregiver, what it means to support our caregivers, and really make sure that they are truly engaged in care. Because as we all know, Our family caregivers are the key to keeping our members living at home as long as possible. We look at behavioral expressions in dementia care and how those can be more effectively managed, and then coordinating care across the dementia continuum, everything from, as I said earlier, cognitive screenings, but also assessing the needs of our caregivers, and looking at appropriate care plans with that, again, dementia-informed lens. So I want to go back a little bit to talking about caregiver engagement, because the D-SNP policy guide specifically talks about that caregivers are important. They have a significant role in our healthcare system, and traditionally are overlooked within our systems as well. They are our hands, our ears, our feet. They do so much in the home and in the community, and yet oftentimes are taken for granted or not even really seen by the healthcare system in a lot of cases. So our D-SNP policy guide does put a lens on caregivers and the importance of them within our care ecosystem that we have. The health risk assessment, the HRA, has to have a question to identify caregivers if there is a caregiver involved in care. So the HRA has that, and those caregivers should be involved in the interdisciplinary care plans and in the interdisciplinary care teams. So it's important to look at, who are our caregivers? Have we identified them? And then also the D-SNP policy guide talks about assessing for caregiver need, particularly with a validated assessment tool. And so really looking at what are the needs of our caregivers so we can ensure that we are connecting them with the care and support they need. Because if we do that, then hopefully they will be able to maintain their engagement and their support of our members living with Alzheimer's disease and related dementias. So next slide, putting that into best practice. What does some of that specifically look like? So the first thing that I want to emphasize is a caregiver is not going to be engaged in care unless they are taken care of first. They need to be supported before we can ask them to be engaged. A caregiver who hasn't slept in several nights, doesn't have respite in place, hasn't taken a break, is not going to be someone that's going to show up in an interdisciplinary care team meeting. They're not going to have the wherewithal to even be able to articulate what their needs are. They need to be supported. That may come in, as I said, in the form of respite. That may come in the form of they need some disease education or they need caregiver training. But we can't expect that a caregiver is going to roll up their sleeves and be part of a care team unless they've been taken care of. And the first thing we need to do with that is to assess them for what their needs are as well. We also, in best practice, need to use culturally competent motivational interviewing to ensure caregiver needs are truly understood and we're meeting the caregiver where they are. Caregiver needs change over time. This is an ongoing conversation. Checking in with a caregiver and identifying their needs today may look really different in a month from now or in 6 months from now, because we're also dealing with dementia. We're dealing with a progressive disease that is going to get worse in time. And so the needs of caregivers are fluid, and we need to be having those ongoing conversations. I can't stress enough, the potential for caregiver burnout needs to always be on our radars. And when we're thinking about care plans for our families, caregiver stress and burnout, the potential for that should be at one of the top things of our list. And respite is such a critical service for so many families. Again, we're dealing with a progressive disease where caregiving becomes more robust over time. And for a caregiver to be able to sustain their role as a caregiver, they need support, and respite is one tool that can be utilized to provide them to support. And fortunately, with our Medi-Cal system and community supports that we have health plans that have respite in California to be able to support our caregivers. Now, we know that not all caregivers are going to be open to respite. They may not want a stranger in their home, or they may not know someone that they can hire as a respite worker. We have some caregivers who feel like they're the only one that can do it, and they just don't want to give that over to someone else. But our experience is generally that when we are able to anticipate needs and we're able to get respite services in place, and even though it's not the end all be all and it's not a long-term solution, but being able to get some relief for caregivers is an amazing tool for being able to support them in the long run. But it's not just one conversation on one day. It may be multiple conversations and utilizing that motivational interviewing. But a lot of times for our families, once they've tried respite, it's really hard at that point to close the spigot because they see the benefit of it. They have felt the benefit, being able to leave the house, get something done for themselves, relax. We had a caregiver, the only thing they wanted respite for was so they could get on the bus and buy some new shoes so that they could continue being in the home and being on their feet all day. So people use it in different ways, but it can be a really important source of support and relief for our caregivers too. But again, a one-time conversation may not be sufficient in propelling forward and moving a caregiver to being able to accept respite and see the benefit of it. We also, in practice for caregiver engagement, need to acknowledge limitations. Our caregivers are asked to do so much. In fact, a lot of what we ask our caregivers to do are things that professionals go to school to learn how to do. And not all caregivers can absorb all of these responsibilities. We have caregivers who are taking care of their own children and their parents. We have all sorts of different caregiver roles and responsibilities and different family dynamics that occur. And so we have to acknowledge limitations as well. Our caregivers can't necessarily do everything, and they may not be able to do it in the way we would hope, but we need to work with them where they are to be able to understand how their life is formed and how we can make this process of caregiving as smooth as possible, giving limitations and given restraints and resources as well. So another D-SNP requirement, and one that I think is so incredibly exciting and puts California really at the forefront, is we have now California Integrated Care Management, CICM. And our health plans, our D-SNP plans, are required to provide care management to adults with documented dementia needs. So what this first means is this does not mean that they need to have a dementia diagnosis. They need to have documented dementia needs. So this may be someone who's showing signs of cognitive impairment, and maybe they have certain safety issues at home. Maybe there's been a wandering incident. And this is really important because, as Barbara said, because we know that people with dementia are under-recognized, and oftentimes it's not disclosed or documented in medical records. This program doesn't exclude them because they don't have a documented diagnosis. In fact, it includes them if they do have documented dementia needs. CICM needs to establish, our D-SNP plans need to establish a model, a care management model that renders what the state previously was calling ECM-like services. And so we have on the D-SNP side of the house and the non-D-SNP side of the house, two different programs that can support people who have dementia. We have ECM and different populations of focus. And for CICM, we specifically have a population of focus that is adults with documented dementia needs. And those CICM services need to be similar to the services rendered through enhanced care management or ECM. Every D-SNP has a model of care, and in that model of care, it delineates how they are providing these CICM services. They can be provided in-house by the D-SNP plan, or they can be provided, and they are encouraged in the D-SNP policy guide to provide these CICM services in partnership with community-based organizations who have dementia expertise. And I'd really like everyone to consider what your models of care look like. And if you're not a health plan, what is the model of care of the health plan that you most closely work with or associate with or have families with whom they are affiliated? Because we want to make sure that when people are getting CICM services, that they are having access to the full array of dementia-related supports and services that are going to maintain their ability to care for the member as long as possible in the home and community-based setting. And it's really important that there is an honest assessment of the health plan ability to provide this full range of supports. Care management for someone with dementia, of course, includes medical care management, behavioral care, dental care, vision care, hearing care, right? All of those things are part of our medical management model and are very important. And in dementia care, what is also important, if not sometimes even more important, are all of the psychosocial educational supports and services that are available to people, because that is what helps sustain our caregivers and allows for community, home and community-based living. So we need to assess, are our health plans providing dementia disease education? Do they provide caregiver training opportunities for Alzheimer's caregiving? Because that looks different than caregiving for other conditions as well. Do our health plans have support groups for people living with dementia, for their caregivers? What do those support groups look like? Are they available in multiple languages? Is there cultural competency in those support groups? Are our members with dementia, are they offered activity programs to keep them socialized and engaged during the disease process? And are there activity programs that engage the person living with the disease and also with their caregiver or their care partner? If our health plans don't offer those full range of support and services, then my question is, where are our members with dementia and their caregivers getting those from? And in many cases, they may not be connected with those services and supports. But I encourage everyone to look at what is available in your communities. Do you have a local Alzheimer's organization? Can you partner with that Alzheimer's organization to be able to provide those dementia-specific supports? That is going to be what complements the care management that is rendered from the health plans. Next slide. So in practice for CICM, and CICM is really still in the early stages of development from a lot of our health plans, but we need to think about how are we identifying people with documented dementia needs. Probably one of the lowest hanging fruits, and again, not the end all be all, but have we run ICD-10 codes and looked at pharma data? That will give you a piece, a sliver of understanding who some of the members are that could benefit from this program. But we have to keep in mind that ICD-10 codes and pharma data alone are not going to share with us all of the people with our documented dementia needs. We need to look at our HRAs. We need to look at other assessments. We may need to look at some clinical notes to really be able to identify these folks and then make sure that they know that there is a program available to them. We need to look at what does documented dementia needs mean. It is delineated in the D-SNP policy guide, but again, not being focused on just a dementia diagnosis, but also having cognitive and functional limitations that would require someone or would necessitate someone getting additional care management services. And then, as I mentioned, really looking at quality dementia care includes the full array of services and supports. And so I really encourage us looking at complementary care models with local Alzheimer's organizations who have deep roots in the community, have expertise, who have these services and supports in place. If our D-SNP health plans can provide the care management services on the Medicare side, that's wonderful. But then let's complement that with the full array of services and supports that our families need for best practices dementia care. I know our organization, Alzheimer's LA, is talking to many of our local health plans about what a complementary care management model for CICM could look like. And there's a lot of really exciting conversations happening about that, so that we really are utilizing the expertise that the health plans have in-house, but also that our organization, for example, Alzheimer's Los Angeles, has, and that is expertise that other Alzheimer's organizations may have as well. So in summary, California has laid a really strong foundation for quality dementia care for those most vulnerable. This always makes me really proud to be in California and to be able to say, look at what we have, look at what our state, our Medicaid agency has put into place for people with dementia. Finally, elevating this population. Our duals are vulnerable. Our duals are not always receiving the full access that they need to services, and our families affected by dementia have been long overlooked by our healthcare system. So it is really quite exciting when we see what California has put in place. But then it's up to us to operationalize this. These D-SNP requirements can fill your dementia toolbox. They can make it robust. But we need to look at how we put these into practice, because it's one thing having a D-SNP policy guide and it's another thing operationalizing these things and really making sure that we're going from policy to practice. And I encourage everyone, look at your resources in your community. We all have our areas of expertise, but how can we partner to build systems of care that are responsive? How can we partner to train staff? How can we partner to provide complementary care so that at the end of the day, it's our members living with Alzheimer's disease and dementia, and it is our family caregivers, our care partners, who are able to gain the full benefit of these partnerships and really ensure that we impact the experience they have while they're on this disease trajectory. You know, I always hope that with an ever-changing landscape, you know, one day we will have the medical treatments to change the actual trajectory of this disease, but we're not there yet. And so what we can impact is the experience families have while they're dealing with this disease, and being able to partner and being able to make sure that our families get education and support and respite and get into a support group or become part of an activity program can really change what their experience is. So I will stop there. We can open up to questions.
Thank you so much. And we did not, as of yet, get any questions, and we do have a really good amount of time. And I think what we've heard as questions is really about what is the requirement? How do we implement this? I think you provided a lot of those answers in a really great way, in a really concrete way. But I'm just wondering, does anyone have any questions? Maybe you're thinking about implementing, you're thinking about how you're going to define your population for this to meet this metric. But I think it's possible you guys did too well of a job. Too good of a job. Sorry, that was the wrong.
Anna, I'll say, I mean, I'm not one to be quiet, so
Yeah.
let's talk here a little bit. But I started teaming up with Barbara about 12 years ago when our state was doing CalMedi Connect. Barbara had already been in this space, and I was kind of the newbie coming in. And in a decade, we've made so much progress, and yet I can count on one hand the number of plans that I've been able to sit with who have actually run their data.
Hmm.
Right? And that is concerning, right? And there are barriers, and there are real barriers to why that can't happen. However, I want to just encourage everyone, whether you're sitting at a health plan or you're sitting in the community or in other spaces, who are these members? Because how do we ever expect to do quality care management if you don't know the disease processes that these members have, right? We can't put someone in a diabetes care management program if you don't know they have diabetes.
Right.
So
We're in
how
this.
do we expect to do this for dementia when we don't even know whether the person has a cognitive impairment? So we really need to start unpacking some of these things. And again, there's real challenges. Our health plans and a lot of our health plans in California have delegated models. And so our providers are working in one EHR and our health plans are working in another EHR. Are the two talking to each other? How are we disseminating this information? If a care manager at the health plan does the cognitive health assessment, how does that get down to a provider to then do a full diagnostic workup? Right? There's a lot that we really need to roll up our sleeves and think about what these systems look like so that we can start doing a better job for these families.
That's a perfect segue. We did just get a question. And I think what you're saying is like, this is not something we've been proactive about in the past. So places are not really set up to just quickly run their lists and see who still needs a screen. It's pretty much totally new to folks. I know where we are, like when we look at who has dementia, and we do not even often include MCI, but sometimes we include some of these codes of like, cognitive complaints or other things that might mean that person has started to be recognized or cognitive impairment. Um, we found it's really hard to identify who has it already in a consistent way so that we know who to exclude and who to care manage in a different way. And then, we see that basically the diagnostic prevalence within that kind of stuff is clearly too low. So you guys were saying about 20% of a dual eligible population, and we'll see like 2 to 6% roughly. So a lot of room to go and a lot of room to improve. And I think what you're getting at is like once we start screening folks, we'll be able to really dig in on, okay, how do we streamline and improve all the rest of what needs to happen, which you already started to highlight really well, of like getting a better, full workup diagnosis, engaging with the caregivers, which I thought you did a really beautiful job of talking about what a priority that is. But we have a couple questions that I think get at this, which is, so this is at the health plan because they're offering the D-SNP on one level, and you said it could be screened at the health plan or the clinic, and by anybody in the clinic. So it doesn't have to be the, primary provider. But are the health plans that you know of making relationships with the health systems, because they're probably working with more than one, to coordinate this work, or are they somehow getting the data in another way? Like, what are you seeing, if you know?
Well, I can say this. So when we started dementia care specialist training about a decade ago, and I was doing some of those training programs, and we were talking about the role of a dementia care specialist, you should be doing a validated cognitive screen. We had worked with one health plan. They said, "Oh, we screen our members." It was for psychosis. It wasn't even for dementia, and they weren't aware of that. So we started teaching how to do a validated cognitive screen. And the dementia care specialists, the care managers at the health plans, were really enthusiastic about having this tool. And then they would say, "But Jennifer, this is great. I can administer this AD8, but then what's going to happen?" And it was very frustrating for our care managers because they said, "Well, where does this go? And we talked about, well, we need to develop some workflows and processes. And we worked with health plans. One health plan we worked with developed a template letter that then they would send to the PCP that would include the results of the validated cognitive screening tool. And then from there, hopefully the PCP would go ahead and do a full diagnostic workup. I think what's exciting, again, when we look at the foundation that California has laid, it was always very hard to talk to those care managers and say, like, this is what it should be. But then, if we fast forward, we get to Dementia Care Aware. And now California is investing in the training of primary care providers to do cognitive assessments. What a remarkable initiative that our state took on and has invested in. And when you read the D-SNP policy guide, because this has been my favorite reading for, many, many years before I go to bed every night, but read it. I mean, Dementia Care Aware is woven into our policy guide for our state. We have a mechanism. We have training and support for our providers. So whereas at one point that didn't exist at all, Dementia Care Aware has tried to harmonize our systems, right? And kind of bridge between what happens at the health plan level and what happens in the provider's offices. But there's still so much that needs to be done in those spaces. I wish I could say, yes, we have figured it out and we have a very cohesive system of care. We're not there yet. But I will say it takes champions. It takes champions to do this work. And we see amazing success when we get champions who roll up their sleeves and say, we need to make this happen.
I'll toss in here another external factor at play, and that is if you've been tracking the advances in research, what is clear is that what's being developed is for people in the earliest stages of the disease. So it is becoming even more urgent that people are screened and diagnosed as early as possible so that they can take advantage of these new interventions, medications, infusions that are coming online. So if you are within a health system and you are trying to operationalize this and you're running into barriers, that's another factor that you can put into the case you're making for why this is worth investing in within your health plan or your health system.
Yeah, hopefully the future will be so much more proactive. And what I'm getting from some of your responses is like, we're just getting started. We're we have some of the foundation and infrastructure, and obviously we're going to learn more and need to continue to build this out. I definitely want to make a plug. So the next question we just had, and I'll also go forward on the slides because we have your emails, and someone said, is there a link to any specific training course that could qualify health plan, social work, and nurse care managers to be deemed a DCS, dementia care specialist, or is it up to the health plan to decide this? And yes, you responded that it's up to the health plan, but I don't know if you want to say more about, the training that you guys do and what you think about like how people should connect to training.
So I really appreciate that question, April, because the D-SNP policy guide does not say this is a training program and this qualifies someone as a dementia care specialist. It gives certain content areas that need to be covered. But I will say, and I applaud the state of California that we have anything for dementia care specialists. But, when I think of the word that you're a specialist, to me, that carries a certain amount of like, wow, training and expertise. So, to take a couple hours of training and deem someone a dementia care specialist, I'm not sure it does justice to it. But the state does encourage the health plans to leverage existing trainings that have been developed by Alzheimer's organizations who have this expertise. When we initially at Alzheimer's LA developed this training with other partner Alzheimer's organizations throughout the state, we went to our health plans and said, what's reasonable for a dementia care specialist? How much time would you be willing? Because we think that a dementia care specialist, again, we're Alzheimer's Los Angeles, we think a dementia care specialist should have, 800 hours of training, or I'm joking, but, our level of what that means looked a little bit different. And boots on the ground, what's actually practical, right? We had to marry the two. And our health plans kind of came and they said, probably about 2-ish days of training is the most that we're going to be able to give to our care managers, to be able to take the time to do this training. And we said, it's not quite what we would hope for, but let's do this. Let's make this work. But again, going through our training program, that's about 2-ish days. Again, we slice and dice it into 4 segments. Isn't the end all be all, right? Because that's the start of this training as a dementia care specialist. And then we offer huddles, and Dementia Care Aware is continually offering additional webinars and support. So what we really hope is that we cultivate our dementia care specialists to be champions and to be advocates and to want to be in this space so that they will continue with their learnings. But please, if you'd like to have a conversation, with us about our dementia care specialist training, we certainly would love to have that conversation. I'll throw my email again in the chat. And if anyone just wants to have a conversation around these topics, clearly we're excited and we're passionate about it. And Barbara and I, are always happy to engage and have conversation as well. So.
Thank you. I think I'm just putting up the CE credit and CME credit information if you guys would like to claim that today. I will say also, as a response to some of the questions, obviously we do training in a lot of aspects of dementia care. So always happy to do that. Some recent examples, because of the D-SNP requirement, have been a health plan and have been a health system. So both on the direct care provision side and the health plan side. And the health plan also is very interested across different aspects of their groups, like long-term care, primary care, home-based services. They were interested in training for everybody because they know they're also going to be supporting providers through some of this. So just to point out that I think this is a really interesting example of a requirement coming through that affects and is getting the attention of different parts of the health system. And you guys, have done, in a lot of ways created and defined the dementia care specialist training. And so I hope people reach out to you to get that training. I'm not seeing any more questions. We will wrap it up as people's lunch hour wraps up. Please do reach out to us if you weren't, for some reason, able to get Jennifer or Barbara's information. If you need anything from us, we have multiple programs to support this work around working with caregivers, working with Dementia Care Aware and training. I think locally, the Alzheimer's organizations like Alzheimer's LA, Alzheimer's Orange County, Alzheimer's San Diego that Jennifer already mentioned are a really important resource. And then there's other sort of national resources from another Alzheimer's organization, Alzheimer's Association as well. So we just really like to bring people to all the resources that we can. And I just want to thank everybody for their time, and particularly you, Jennifer and Barbara. Thank you so much for doing such a wonderful job and just, again, making it really concrete and really applicable during this exciting time of change. So thank you for your expertise and your time today.
Thank you, Anna. Thanks, everyone.